Good evening to all of you. On behalf of Heartline mini series, it gives me immense pleasure to welcome each of you to our episode 5 of this academic journey. Today, we will explore a subject that lies at the very core of perioperative and critical care physiology, that is, the heart lung interactions in the OR and in the ICU. These interactions guide our decisions every minute, shaping our hemodynamics, ventilation strategies, and overall the patient's outcome. Understanding this will delicate a dance between the heart and the lung, which is essential for every cardiac anesthesiologist, intensivist, and the trainees. We are deeply honored to have with us our respected speaker, Dr. Elvis Senthil, whose clarity, clinical wisdom, and experience make this complex physiology beautifully understandable. His insight promises to enrich our practice and inspire our thinking. Thank you all for joining us this evening. Let us open our minds, learn together, and continue strengthening of the Heartline family. So, with that, I humbly invite Dr. Elvis to begin our today's session.
Hello, good evening. So today I want to thank Dr. Mona Lisa and the WACTA team for giving me this opportunity. So already really expert people have talked about this topic before me, but today I would be talking about it in a slightly different perspective. So this class will try to get into why, the how, and all the nuances you can get. Because I feel like everything in nature is like way more complex and it's more beautiful because it's complex and as a result of it. So today we'll talk about the mechanistic systems. So underlying all of these are like a series of interrelated systems, and all of these complex sometimes systems act in opposition and then in synergy, and ultimately they provide these effects. So you have like a black box, which is the whole human system, and you can just check the outcomes like the BP or like whether the urine is coming, but you don't really get an insight into what it is. We have a few techniques to like see into it, like the TE or the PA catheter, but ultimately we just like assume based on the outcomes. So this is like multiple black boxes. You cannot see what is happening in the heart exactly. So this black box is inside a larger black box, which is the thorax, which also has the other boxes, which are the lungs. Now all of these are like going to interact with each other as they function independently. So rather than telling you like based on, in you take a positive pressure breath and this afterload decrease, I'll try to talk to you about how it interplays with systems based on their, along graphs and along certain paths. Because rarely is anything as simple as like, you give more pressure, you get less blood flow. It's usually dependent on each patient, what is their fluid loading status, what is their disease status, and so on. For example, an obese 80-year-old patient with ARDS is not going to react the same way as a 23-year-old patient with ASD. So rather than rely on all these dictums and telling you, okay, this will happen if this happens, I'll try to explain why it happens. So when you analyze things by yourself, you don't fear complex scenarios. So when you can take a complex, a patient, which is a complex scenario, and you can simplify it into a series of smaller bundles, then it becomes interesting. It becomes fun. It doesn't become as scary. So that is what I'll try to do today. So first we'll talk about ventilation, because I mean, like we all understand ventilation, but like I'll try to give you a newer perspective or a different way of looking at it. Now, this is a Campbell diagram. I'm not sure how many of you know it, but it's a very interesting way of looking at the whole ventilation as a system. Because when you take ventilation, you're just like having a, the alveoli expand and contract, and that's what's happening. But underneath it, it's like two major things which happen simultaneously. One, your lung, which comprises of the alveoli, the alveoli, and the parenchymal tissues in between, and the elastin and collagen there. And the other is the chest wall. The chest wall comprises obviously of the ribs and the muscles and the tissues in between, but also the abdomen and the diaphragm. Because you have to realize that the chest wall does not exist in an isolated system. Whatever affects the abdomen is going to affect your chest wall. Because if you remember, one of the ways to asphyxiate someone is to just press on their stomach. If you compress the stomach well enough, they will not be able to breathe a lot, and that itself is enough to asphyxiate someone. This happens in certain, RTAs and when trees fall and stuff. So we take these two independent systems, which is the lung and the chest wall, and they're all linked, and they're linked together because of this thing called the pleura. So the pleura is what happens. It mechanistically links the lungs with the chest wall, and the combination of the two is what gives you the characteristic of the respiratory system as a whole. Now, if you take a look at this, let me use the pointer on the screen. So this is the C lung, which is the compliance of the lung. Now, first, whenever you look at a graph, I always recommend, let's talk about the axis. So the ordinate or the x-axis, we have the pleural pressure of the lung. So this goes from 0 to +2 and to negative. Mostly when we talk of pleural pressure, we're going to be in the negative zone. So we are seeing most of the useful things happening in this negative zone. And when you take the y-axis or the abscissa, you have the volume. And we talk about it as a percentage of the vital capacity. Like say, like the top of it is the 100% of the vital capacity, and at the bottom is zero, which is like your lungs are completely collapsed. But in reality, this does not occur. So there is a minimum amount of volume which will be in the lungs, which you cannot expire this thing. So this will be the residual volume. So the FRC is here. It's usually around 35%, but it alters based on the clinical scenario and the disease condition. So the lungs, as the pleural pressure becomes more negative, the lungs expand, the increase in volume. So this line which is drawn is the compliance of the lung. And as you know, compliance is the volume per unit change in pressure. So now let's look at the lung alone. So what happens is this is the normal compliance curve. And when you have an increased compliance, and the increased compliance of the lung usually occurs in situations like emphysema. And you can have a decreased compliance of the lung, which we commonly see as a pulmonary edema, but it can be in ARDS, in pneumonia, or even in certain other disease states. So what happens, as you see, if the increase in the compliance for the very same pleural pressure, suppose the pleural pressure here, this dot is -8, it is only at 50% of your vital capacity. If your compliance is increased, it goes to around 80% of your vital capacity. Whereas if your compliance is decreased, it's only around 30% of your vital capacity. Now, going back to this, when you put these two together, you get some extra information which you do not get by just seeing them independently. So one very useful thing to look here is this dot, which shows you the FRC. Now the FRC is the functional residual capacity, and I'm sure you all have like the definitions like in your head like very well. But if you look at these two curves and you realize that the point at which there is no force exerted on these two systems, the compliance of the lung and the compliance of the chest wall meet at a point, and this is your FRC. So at this point, the lung is trying to pull in and it's trying to collapse inward, whereas the chest wall is trying to collapse outward. It tries to become bigger. So this is your FRC. Now from your FRC, you want to go to an inspiratory point. Let's say you have inspired to 50%, which is your normal tidal volume. You have gone from this point on your FRC to here. So what happens is you have opened the lungs up. You have pulled the alveoli open, and that is exerting a resistive force trying to collapse it. And the chest wall, you have actually, the chest wants to stay compact, but you have like made it, no, the chest wants to stay open, but it's actually being compressed down. So this state where it tries to open up, but you are stuck here. So this point is your normal point of end inspiration at tidal volume. Now, what is the force which is generating is the difference between these two is your muscles. So this is your diaphragm, your intercostal muscles. This is generating it. Okay, so we have gone into this. I'll try to go a little faster. If at some point you don't understand, you can message me later. So on the left side, we talked about the lung compliance curves. On the right side, you see the chest walls compliance. Now the normal chest wall compliance, it's usually trying to open it. But if you have a positive pleural pressure, which can occur in pneumothorax, for example, the chest wall actually tries to collapse inward at that point. So it usually physiological ranges, it tries to open up. It tries to move away from each other, the anterior and the posterior walls. Whereas if you have too much air, like in a positive pressure ventilation, or if you have a pneumothorax. At that point, the chest is so open that it actually tries to gets back. So the chest tries to gets back to its neutral position. So if it is at a negative pleural pressure, it goes to this point. If it's at a positive pleural pressure, it tries to go back to this point. Now, when you have a decreased chest wall compliance, and this is going to be important because this occurs in a very obese patient, for example, or if there is mechanical trauma, or if there is ascites. Okay, so these are scenarios which you may encounter. So when this occurs, what happens is the slope of the curve actually comes down. Now, one point you have to note is that there is a separate thing called capacitance. Now, when you have a very obese patient, instead of actually decrease in the compliance per se, you have a shift to the right. So this is going to be an interesting thing when you consider what are the effects of PEEP or what are the effects of ventilation in an obese patient. So it may not always be the same as you would get in a normal patient. So understanding this is important. So coming back to understanding the ventilatory mechanics, we follow the bag and straw model. Basically, we consider all of the things from the mouth till the terminal bronchiole as a tube. So air has to cross this area and this causes a dynamic pressure change. Okay, so this is going to be the energy which is required to push air through a narrow tube. So this is in opposition to the static pressure. The static pressure is the energy which is required to enlarge the alveoli. Now the alveoli is going to resist expansion because it has elastin and collagen in its walls and the parenchyma. So this is mainly a function of volume. So the static pressure is a function of volume and the dynamic pressure is a function of flow. So if you look at it, the airway pressure, which you normally see in the ventilator, let's say it's 25 centimeters of water at peak. So what it is it's a combination of a static pressure due to the volume change and a dynamic pressure due to the flow. So if you have a higher volume change, you have a higher tidal volume given, that multiplied by its compliance will give you the static pressure. And okay, so there's a simplification here. You have to remember that elastance is a inverse of compliance. And if you multiply the volume by the compliance, that is what gets you the static pressure. Whereas the dynamic pressure depends on the flow and the resistance of the airway. So for example, you have a patient with bronchospasm, the resistance is going to increase. So the dynamic pressure increases without much change in the static pressure. The airway pressure is risen because of this dynamic pressure. Whereas the static pressure is purely due to the volume change, and this can be measured as the plateau pressure. So the static pressure is plateau pressure because at plateau pressure there is no flow. So the dynamic pressure becomes zero and what you're left with is the static pressure. Okay. So now on the right, we are going to look at what is the work of breathing. So the work of breathing is the area between these two lines. So we started at FRC, which is end expiration. We ended up at this point, which is end inspiration. With this is the normal tidal volume. Let's say it's 500 ml. So to get from here to here, your body had to put some energy in. Now this energy is partly due to this resistive work of breathing. Now, in this diagram on the right, you can see that is the line doesn't go directly. You have an increased, pathway. This is because the body has to overcome the resistance of the air. So this resistive work of breathing is usually dissipated as friction and heat. Whereas this red area is the elastic work of breathing, which is merely due to the compliance and the change in the volume of the alveoli and the lungs. So this is stored as a kind of elastic energy in the elastin and the collagen fibers. So when you exhale, this is what is going to, this energy stored here will be used to drive the air out of the lungs, and that is your expiration. Now there is this gray area, which is the work which is used to compress the chest wall. So even as you expand the alveoli, you are compressing the chest wall. So this is an idea about the work of breathing, which is a more significant thing in the pediatric and the neonatal group. Because in an adult, usually the ventilation is about 5 to 10% of your total metabolic requirement max. Whereas in a neonate, it can go to 30 or even 40% in a very acutely diseased infant. So when you have 30% of your total metabolism going towards something, that is going to alter your metabolic requirements, your cardiac output and load and cyanosis and so on. Okay. So keep an idea of the work of breathing. So let's take two different conditions. On the left, we have a condition where the compliances are altered. So since the compliances are altered, this is a static pressure is going to increase. So what we see is that the grayish lines in the background are the normal compliances. This is the lung compliance and this is the chest wall compliance. But here you see, because this compliances have increased, the lines have become flatter. So let's say this patient has pulmonary edema and also chest wall edema, which is seen in like child, or there is ascites and pulmonary edema. So now what happens is, this area which is used to stretch the lungs and area which is the energy which is used to compress the chest wall becomes bigger. So you have a larger work of breathing. So your body tries to compensate for this by moving from this upper part, which is the normal FRC, to your tidal volume area, to a lower, shallower part. So you take rapid, shallow breaths. Now the problem with taking rapid, shallow breaths is, yeah, you are getting more volume in and out of your lungs, but you end up with more dead space ventilation as you take smaller, shallower breaths. Okay. So the other thing is you have to think about is, suppose there is a bronchospasm. So what happens is that there is increased airway resistance. So the compliances of the lung and the chest wall are the same, but the path, to get from your FRC to your inspiratory area, you have to take a longer path. You need more negative pleural pressure to reach the same tidal volume. To get to this, so you are expending a lot more energy for the given amount of elastic recoil. So what happens is that your body tries to take a slightly deeper breaths and slightly lower rates. It is, at least initially it does that, till your higher sympathetic stimulation kicks in and you get tachypnea. So initially you try to go into this part, which is what also people do, because you want to get into, go from somewhere from 50 to 70%, which is mechanistically more efficient than taking rapid shallow breaths. So this is the difference between having altered compliance and having altered resistance to the airway. So if you take a look at this, it actually gives you a similar vibe to how aortic stenosis, you have a limited output. So you cannot, you do not want to take a lot of, you have a less rate and more efficiency. So what happens in this bronchospasm scenario is that if you try to take more rapid breaths, that the expiratory alveolar collapse will occur, because even expiration becomes more energy requiring. So if you take more breaths, you actually end up doing less work. So the work is done is less. So your airway volume is taken in is less. So you do not want too much tachypnea in a resistive bronchospasm scenario because of this. Now, these are some reasons for changes in your compliance of your pulmonary and the chest wall. I'm not going to go through one of them. Just remember that the common things we see is pulmonary edema, emphysema, and hyperinflation, that is dynamic hyperinflation, and pneumothorax, which you can see in the post-op scenario where the drain is blocked, or you remove the drain and you get it. Whereas a chest wall, you see in thoracotomy, which we encounter on table, and you get like extra pulmonary ARDS, pancreatitis, and other cirrhotic conditions. You can get this extra pulmonary ARDS, and also obesity. So chest wall edema or air is another thing which you can rarely encounter. So proning is another thing which you will encounter if you're going into ARDS, ECMO, and like the ICU. So that is also another scenario where the chest wall in compliance actually decreases. So far we had been talking about negative pressure ventilation or spontaneous. So which is what we get on the left. So now another thing to keep in mind is that in positive pressure ventilation, you cannot use the pleural pressure to look at the compliance of the lung and the chest wall, because you're going to have a positive airway pressure. Now the airway pressure is different from the pleural pressure. The pleura is what in spontaneous you have the chest wall moving due to the muscles, creating a negative pleural pressure, which leads to a transpulmonary gradient between the chest wall and uh, the pleura and the alveoli, and that is going to cause air entry into the alveoli. So that is your ventilation. Whereas in positive pressure ventilation, so what happens is that you're going to have the airway pressure. We are going to use a different x-axis variable. So as the positive pressure increases, the lungs are going to expand, and that is going to push on the pleura and the chest wall, and that is going to cause a compression of the chest wall. So this is a difference. Now we can look at the compliance of the system as a whole. So what we do is we can see the transpulmonary gradient, which is the difference between your chest wall and your lung pressure at any point of volume. and then you measure this, and then you draw it from the x-axis, you get and you mark it. So this will give you the compliance of the respiratory system as a whole. Now, the same thing for a positive pressure ventilation is actually the difference between the two lines, because that is where so it is the addition, it is the sum of these two pressures, whereas in negative pressure it is the difference between the two. So this is because in negative pressure you're trying to move the chest wall away from the lung and then produce a respiratory drive, whereas here you're trying to move the lung into the chest wall and produce the respiratory drive. So this is the, you can see the lung compliance is drawn to the right, but it's basically a reflection. Only thing you have to note is that it doesn't touch zero, just as with before. Now let's talk about peak and plateau pressure shortly before we go on to the rest. So if you draw the hysteresis curve of the volume of the lung as with the positive pressure of the airway, so you get a curve like this. So initially, as the volume increases, sorry, as the pressure increases, the volume increases. So at a point where the maximum airflow is there, that is where you have the peak airway pressure. And once your flow is stopped, the point at which there is no more airflow, so this is purely due to the compliance and the compliance of the whole respiratory system. So this is your plateau pressure. So the pleural pressure usually tracks very closely to the chest wall unless you have some rare conditions like pleural effusion or pleuritis. So mostly whatever is the chest wall pressure, that is your pleural pressure. So keep in mind these few fundamental concepts as we go into more things. So a few implications. So oxygen consumption of ventilation is significant in neonates and in patients with significant airway obstruction. One example which you can see is actually in patients with TOF with absent pulmonary valve. So what happens is that the large pulmonary arteries compress the trachea and they cause an airway obstruction in these children. So you get like a very hyper tachypneic children who are trying to take a lot of breaths. In those cases, the oxygen consumption of ventilation itself becomes significant. So once you reduce this work of breathing, you actually reduce the cyanosis in these patients to a degree. So other thing is mechanically assisted spontaneous ventilation. You have weaning modes like SIMV spont, NAV BiPAP. So here the pleural pressure is often negative even when the airway pressure is positive. The respiratory muscle and the work of breathing is unloaded. That's all you're going to have. But the pleural pressure is negative and the airway pressure is positive. So for most of your scenarios, if you look at this, the pleural pressure closely tracks to the chest wall pressure, and that is what is going to affect your heart. So for the rest of it, whenever we talk about heart-lung interaction, the pleural pressure and thus the chest wall compliance curve is going to be what is relevant for what is actually affecting your heart from the outside as a direct compression in the thorax. Now, one more respiratory thing which I want to talk about is autopeep. It's also called intrinsic occult or autopeep, which is a kind of peep. So now you have to know what is the difference between autopeep and dynamic hyperinflation. Autopeep is the presence of end expiratory pressure due to airway collapse, whereas dynamic hyperinflation is when you actually have breath stacking. So the alveoli expands to say 300 ml of tidal volume, but it is not exhaling all the 300 ml volume. Instead, only what 200 ml is exhaled. So 100 ml is left in. So the next breath that again goes plus 300. So you have plus 400 and it exhales 200. So the breath stacking occurs. So hyperinflation is a volume phenomenon and autopeep is a pressure phenomenon. Autopeep leads to a dynamic hyperinflation, but they are not the same. So now occult. So occult is hidden. That's what the word means. It's beyond the realm of human compression according to a dictionary entry. So in our practice, what you have to realize is that autopeep is way more common and often missed in our practice. So this occurs even in a healthy patients in the dependent areas. Whereas if you take a recumbent patient who's obese, you have patients with lung injury or emphysema, or patients who have like recovering from a pneumonia or who have a lot of secretions, these pooling of secretions can cause dependent autopeep even when the rest of the lung is good and you don't have any bronchospasm. So you have to understand that autopeep is very deleterious. We'll go about it later on. So I'm going a little bit behind on time, so I'll try to hurry up. So yeah, so how to identify auto peep? So the machine, the ventilator itself will tell you what is auto peep sometimes, but it is not very reliable. So if you are having a volume control ventilation, you can use the stress index. This will let you identify. So if the stress index more than one, you have a final increase in the slope at the end of expiration. So that is going to be suggestive of auto peep. So auto peep actually, contrary to popular belief, it responds to extrinsic peep because extrinsic peep is going to splint it open, and you have to realize auto peep is a local phenomenon. It is not throughout the lung. It's not a homogeneous auto peep. It's going to have certain parts which are more likely to have auto peep than others, usually at the dependent parts. So putting an external peep is going to splint it open and prevent this. And this is important because even though the external peep is not going to reduce the overall end expiratory pressure, it is going to prevent the dynamic hyperinflation, which is very deleterious. Now, this dynamic hyperventilation shifts the ventilation to the less compliant part of the curve. As we saw here, it is going to shift the curve ventilation from the very comfortable part where the work of breathing is less to a higher up part where the work of breathing is more. So the other thing is that pleural pressure is going to become more negative, and that is going to have more deleterious effects on your hemodynamics. And finally, patient ventilator dysynchrony becomes more common because the pressure which the ventilator senses is not actually the pressure in the alveoli. So this is because of this auto peep, and this is going to cause a lot of problems in SIMV or SIMV modes. Now, pressure control ventilation modes don't work well with auto PEEP because it is going to deliver less tidal volume because the machine is not sensing your actual airway pressure of all the alveoli, and certain parts are going to collapse. So the end tidal expiratory volume, the inspiratory volume won't match, and you have decreased tidal volumes. So your body has tachypnea, and tachypnea worsens auto PEEP. So this is why in certain cases, decreasing the respiratory rate improves ventilation in patients where you have auto PEEP. So you're thinking PCO2 is high, I have to increase the respiratory rate, but actually auto PEEP will worsen with tachypnea. So you can try altering the IE ratio, try nebulization. So, and giving some external PEEP, that will actually help in these cases rather than simply increasing the respiratory rate. Now, one more thing with auto PEEP is that it's going to increase the transpulmonary pressures, worsen VQ mismatch, and RV offload. We'll talk more about this as we go into the mechanics of blood flow. Now, the circulatory mechanics were classically described by the Frank-Starling curve. In the Frank-Starling curve, you have the uh, preload along the x-axis and the cardiac output, which is here described as the blood flow in the y-axis. So now let's just take the point 1, the curve 1. So if you increase the uh, preload by say the increasing your CVP from 3 to 8. So what is going to happen is that your cardiac function is going to improve. So this is called a cardiac function curve for a reason because it is assuming that we traditionally think of this as similar to your Frank-Starling curve for the muscle, but actually it's not because you're talking of something coming into the RA and your LV producing an output. So you have all the things in between, which is the all the heart valves, you have the RV, you have the pulmonary vasculature, you have the mitral valve, you have the LV compliance and the aortic valve, and finally that is going to be the cardiac output. So this as a whole reflects the whole cardiac function. So this is called as the cardiac function curve in physiology often because this is going to look at the heart as a whole. Any alteration in your systolic, diastolic function, valvular function.
আরেকটা রিডিং কত দূরে হ্যাঁ ট্রলিটা নিয়ে আসতে কত
Can we have whoever it is mute? Sorry. Okay, so any alteration in the systolic function, diastolic function, or the valvular function, like say MS, is going to cause a decrease in the cardiac function curve as a whole. This is a shift to the down and the right. Whereas any improvement in the cardiac function, usually with inotropes, is going to cause a shift to the left and the above. Also, this is seen with a reduction in the afterload. So we'll go further into that. Whereas the preload is the only thing which is seen as you go from left to right. Now, on the curve on the right is going to be familiar to most of you being cardiac anesthetists. This is classically described by Sagawa. It is the pressure volume relation of a ventricle. I'm not going to go into detail. I'm sure most of you know better than me about this. But when we talk of these two together, you have to realize one thing is this. This is in a single beat, the Sagawa LV pressure volume curve, classically described. Whereas what is seen on the right is for the per minute. So you're talking about the blood flow as the cardiac output in the minute. But we can correlate the two, assuming that there is no change between beat to beat. So what is seen here is this blue line, which is your cardiac output. Okay, so the cardiac output, assuming the heart rate is constant, is a function of your stroke volume. And this blue line corresponds to the stroke volume here. Now, other thing to keep in mind is that the point at which this is seen is the x-intercept, which is the ordinate value. This ordinate value corresponds to the end diastolic pressure. So remember, this is atrial pressure and this is the ventricular pressure at end diastole. But in end diastole, assuming that the mitral valve is open, the RA pressure is going to equate to the LV pressure at this point. So you can see that this is the corresponding link here. So for this end diastolic pressure, you're going to have this stroke volume, and that is seen here as this end diastolic pressure, or the RA pressure is here. Now we are going, so oversimplifying some of the intermittent things like the RA to the RV to the pulmonary to the LA to the LV. So you're skipping all those steps, but assuming those things are normal, this is how you think of the Sagawa and the Frank stalling as related to each other. So if you have an increase in the preload, you're going to have an increase in the end diastolic volume. Because the end diastolic pressure is higher, you have a higher end diastolic volume along this end diastolic pressure volume relationship. And for this higher end diastolic volume, you're going to have a higher stroke volume as this curve, as the area becomes, as the distance, the x-axis becomes larger. Now, Guyton was someone at this point, like you have to see that he did not see merely the heart as something which is post due to the afterload and the contractility. He said that venous return is an independent factor affecting your cardiac output. Now, it is easy to think of venous return as merely the arterial pulse wave going through your arteries, arterioles, capillaries, and then pushing the venous blood into your heart. But this is not what happens. And this is because 70% of your blood is in the venous circulation, and the venous circulation, the veins are extremely capacitive. So they have a large degree to expand and dilate and hold the blood. So this is going to prevent all the arterial pulse wave from actually pushing blood. Instead, what happens is that there is a degree of venous stretch. So this is called the mean circulatory filling pressure, and this was his Guyton's main contribution to this concept of venous return. So he came up with this concept of pressure, mean systemic filling pressure, which is the idea that if your cardiac output is stopped, at that point, how much of the venous pressure or what is the pressure in your major veins, which is going to cause it to empty. So this minus your RA pressure, which is the pressure in the RA, is going to determine the venous return to the heart. So the pressure in the veins, which minus the pressure in the RA, is the pressure pushing blood into the RA, which is what we think of as preload. Now this is the resistance to venous return, which we'll talk about later. So again, so these are concepts most of you are probably familiar with, but I'm sure like you have an idea of the stressed and the unstressed volume. So I will not go too much into this, but just remember that for a specific PMSF, you have a specific curve. This is the Guyton curve, and this is a venous return curve. Now, a shift to the left of this thing, which is due to a reduction in the MSFP, which is maybe let's say due to a change in the stress volume or a reduction or an increase in the venous compliance. So this is going to cause the curve to shift to the left. Now this is also going to cause a change in the maximal venous return. Again, this is a lot of explanation which will take time, so I'll skip through this. I hope you are familiar with this. Just know that a shift to the right can be due to giving more fluids or more inotropes, which cause the shift of blood from the stressed to the unstressed, the shift of blood volume from unstressed to the stressed. Okay, so let's go past this. Just know that, okay, I'm sorry about that. Okay. Now the slope of this line is the venous resistance, which is seen in the denominator. This is usually not a factor, but let's see how it affects. Now, we have these two curves, which is the cardiac function curve and the venous return curve. Now you realize that the RA, pressure of the RA is the common thing, so you can superimpose these two, and the point where these two lines intersect is your cardiac output at that point. So for a given mean systemic filling pressure along this cardiac function curve, so this is the cardiac output you're going to get. Now, a change in this venous return is called a circuit function because this is a function of your venous circuit. So, a shift to the right is an increase in the venous circuit, and a shift to the left is a decrease in the venous circuit. So, combining these two, you get this curve. And based on this, we can understand whether the cardiac output actually increases or decreases. Because in most cardiac scenarios, you're not going to have a pure increase in the preload or a pure change in the afterload. You're going to have a combination of the two. And based on the combination of the two, you're going to have an alteration in the cardiac output. Now, coming to the RV, so far we've been talking of the things in terms of the LV. The RV is similar to the LV except that it operates at a much lower pressure. So in this hazy outline, you can see the LV, and in the shaded outline in the foreground, you can see the RV. So you can see it has a much less contractility, much slower EA slope, which is your afterload, and much increased volumes. But however, know that the stroke volume is the same. But what is to be remembered is that usually the RV operates with a much lower afterload. So any increase in afterload is much less tolerated by the RV. So in this graph, as you increase the afterload, the stroke volume of the LV remains relatively constant. It decreases by 10 to 20%, even as you double, triple the afterload. Whereas the RV exponentially falls down, and if you just like increase the afterload by 2 to 3 times, you can have sometimes a fall of the RV or cardiac output by around 50%. Of course, there are compensatory mechanisms which will kick in, but purely from a speaking isolated RV and LV, afterload is way more significantly impacting the RV, which will affect all the things as we go on. Now we have this concept of the pulmonary vascular resistance, which I'm sure most of you have this idea. Like you just calculate it as MPAP minus the pulmonary arterial pressure minus the pulmonary venous pressure, which is the LA pressure, divided by the cardiac output. But this is assuming that, say, there's a point A1. So you're going to assume that this is the slope, the shaded line one. So by measuring the PVR at this point, you're assuming that this is the cardiac function curve for the RV as the afterload. So this is going to be your, as the pulmonary artery pressure rises based on your afterload, what is the cardiac output? Now, actual reality, the RV cardiac output is a curvilinear curve. So it is initially curvilinear and later on it becomes linear. So this is going to have a lot of mechanistic implications, which we will go ahead in the later areas. So another point to keep in mind is that the pulmonary artery is a very complex system. It has both Poiseuille resistance factors. Poiseuille resistance is basically your formula pi PR per 4, the classical equation, Poiseuille equation, where the flow is proportional to the radius to the power 4 and inversely proportional to your uh, this thing. Okay, the resistance and the viscosity and the length of the tube. So you cannot take the pulmonary arteries as mere tubes, but they become Starling resistors. Now, Starling resistors, what is the concept is that these vessels are not just dependent on what is the blood flow or what is the thing in the vasculature. It depends on what is your alveolar pressures. So as your alveolar pressures alter, instead of moving along the same curve, you actually move to a different curve to the right. So this shift to the right, like going from A to B, is due to these Starling resistors, and this is because your pulmonary vasculature is extremely dependent on your alveolar pressures. Now this is the major point where you have the heart-lung interaction. Okay, so you're going to have this alteration in the intrathoracic pressure, causing a change in the cardiac output curve of the RV. Now, this is a major thing to understand. So let's spend a minute here. Now, when you go from A2 to A1, so what happens is that as your RV is producing more pressure, it is contracting harder, it is able to increase the cardiac output from A2 to A1. So this is what usually happens, and this is a slightly linear relationship at most physiological states. But once you alter the external atmosphere of the RV and the PF, which is your lungs and the alveoli and the intrathoracic pressure, so this is going to cause a change in your RV afterload. So this RV afterload, just remember that it's complex. It has both positive resistance and Starling resistance. Another factor to depend is that there is a flow dependent dilatation of even the arteries. Normally, you know that the systemic veins are able to capacitate, like they're able to hold greater flows depending, greater volumes depending on the flow. Now, pulmonary arteries also have this capability, but this is because they are capable of flow dependent dilatation. So as increase flows through the pulmonary artery, these pulmonary arteries are not as stiff. So they are able to expand more. So you're going to have increased flows without much of an increase in the resistance. So this is again going to compound all of your ideas. So I just want to say this because you have to know that just you have to know that just calculating the PVR and saying that I gave an X drug and the PVR altered, that is not going to reflect the actual reality of the system always. So usually this PVR calculation is useful only when you have either the flow or the pressure constant, like the cardiac output or your alveolar and PA pressures constant. Once you have either of these two changing, so what happens is you go from A1 to B2. So you may think that there is, so you are going from A2 to B2. You think the PVR hasn't changed, but actually the whole system has changed. The PVR, which is calculated at A2 and B2 are the same, but the cardiac output, the pressures are not the same, and the RV is not on the same part. So whatever treatment you give, you think, okay, this is a very good example is in pulmonary embolism. You go from A1 to B2 because there is a lot of change in the outcome. So you don't merely give a pulmonary vasodilator and expect it to improve. So we'll talk more about this later. Pulmonary venous return, again, we ignore this usually, but this also plays a factor. This is usually similar to the Guyton curve, similar to the systemic venous return. Only factor to keep in mind is that different parts of the lung have different venous return mechanisms. In zone 3, usually there is more pressure compressing, the negative pleural pressure is going to compress the vessels and cause a decrease in the capacitance of the pulmonary veins. So increased cardiac venous return into the LA. But the same will not happen in zone 1 because in zone 1, it is going to have a different system because you're also going to have collapse of these pulmonary veins. There is an increase in the resistance. So in zone 1, 2, and 3, you can see it correspond to the curves here. You can see there's not just a change in the circuit function, but also a change in the venous resistance. So just keep in mind that the ultimate venous return to the LA is a combination of all three curves. Now, I'm sure you know about all of these complex factors. The point I want to make here is that RA pressure is not an independent variable. So you do not look at the RA pressure and say, okay, changing the RA pressure is going to change the, the hemodynamics as such. RA pressure is dependent on many things, both on the cardiac function, the circuit function, and the thoracic function, because the RA is a combination of three things. How much is the heart emptying? So what is the RA emptying into the RV and the pulmonary into the LA into the LV? So if you have poor LV function, suppose in failure, so you're going to have increased back pressure and that will increase RA pressure. And that is not necessarily saying that you're having more cardiac venous return. So the other thing is circuit function. If you have more stress, more inotropes, that can increase RA pressure, which will actually indicate more venous return. So the RA has blood coming in, blood going out, and your thorax compressing it. So all of these three factors are going to affect your RA pressure. So next, let's talk about heart versus lung, how they interact in a healthy patient. Now, this diagram on the left is a very important thing. Okay, so whether you have spontaneous ventilation or intermittent positive pressure ventilation, mechanical ventilation, you're going to have increased lung volume. But in spontaneous ventilation, you have a decreased intrathoracic pressure and an increased lung volume. Whereas in intermittent positive pressure ventilation, you have an increased intrathoracic pressure and an increased lung volume. Now, if you do a Valsalva, you're actually going to have an interesting thing where you have an increased intrathoracic pressure without a change in the lung volume. And if you do a Muller maneuver, which is not as common, but basically it is forced inspiration against a closed glottis. So it's in some ways the opposite of a Valsalva. You're going to have a constant lung volume with a decreased intrathoracic pressure. Okay, so if you look along this curve, so a Muller maneuver is going to cause a shift to the left without an increase in the height. If you take a Valsalva maneuver, it is going to cause a shift to the right without an increase in the lung volume. If you take spontaneous ventilation, as you inspire, you're going to have a decrease in the pressure and an increase in the volume. If you take a positive pressure ventilation, you're going to have this curve, you remember the RAN curve where it shifted to the right. So you're going to have an increase in the pressure with a increase in the volume. So this is the whole idea, and we'll look at this, how it independently affects. Now this I'm not going to focus too much on. Just know that expiration is the same in both, but inspiration, you have a pleural pressure drop leading to ventilation. Whereas here the pleural pressure doesn't drop, but there is an increase in ventilation in positive pressure ventilation. So the main thing to remember is that the transpulmonary pressure, which is PL minus PPL, is the same in both. But what is your ultimate, pleural or thoracic pressure is different in the two. In spontaneous ventilation, it is negative. Whereas in positive pressure ventilation, it becomes positive. Okay, so let's see. So let's take this case where you have the previous, the Guyton and the venous Frank-Starling curves interjected. So let's just look at one. So this is your normal heart. So in the line 1, you can see that the Frank-Starling curve, it intersects the x-axis at a point. Now this point is important because let's assume the heart stops working. So if there is no blood flow, at that point, the RA pressure is not having any venous inflow, it's not having any venous outflow. So that is going to correspond to the thoracic pressure. So this is the x-intercept. Now in a spontaneous, so this is the x-intercept. Now the right hand part where the height and the slope at the right part, this is dependent on your afterload and contractility. So let's say we have a heart and we are not going to change the afterload or the contractility. We purely alter your intrathoracic pressure. So what is going to happen? The RA pressure is going to become more negative. Okay, so the RA pressure at zero cardiac flow, that is your pleural pressure. So the x-intercept of this curve is going to move to the left. So this is the idea you want to have here, is that if you change the pleural pressure, only the x-intercept changes. If the height and the right hand part, the compliance of the LV, all these things do not change. So if in a patient you purely decrease the pleural pressure without altering anything else, you're going to see this curve move to the left. Now the venous return curve is the same, assuming. Then what happens is the lines intersect at a different point and you have a higher cardiac output. Now this is what we want to talk about. This idea of using these curves along with these mechanistic implications of respiration. Now another point I want to make it is at zero cardiac output versus what is the pressure, and that is your thoracic pressure. That is the pressure on the thorax on the RA. Now, in normal physiological state, when the heart is functioning, this is the point where you have the RA pressure. So when you measure it in this patient, you have a CVP of around +2. Now, the difference between these two is your transmural pressure, which is the pressure which is the pressure difference between what is the pressure inside the RA, interluminal pressure, and the pressure outside the RA. So this difference, the transmural pressure, is going to determine your venous return to the heart. Now so we have combined two, the Frank-Starling and the Guyton curves here. Now what if we combine the Campbell curve into this? This is like gonna complete the whole thing. We have this thing. So let's put the Campbell curve behind the screen into the Z axis. Okay, so now you get this 3D graph. So you have the Campbell curve which goes behind, and the Guyton and the Guyton venous return curve, the cardiac function curve, and the Campbell curve which goes behind. Now the common x-axis is the RA pressure. Now as I told you, the RA pressure tracks with the pleural pressure because that's the thoracic pressure. So using this, we can get a lot of information about how, as you move in this respiratory along the lung compliance and the chest wall compliance, what happens to your cardiac output. Now, combining these three is going to look complicated, but once you get the hang of it, we will see. Okay, so let's take this case where you have a negative pleural pressure without a change in the volume. So there's no change in the afterload much. So what happens is that as your negative pleural pressure decreases, the cardiac function curve shifts to the left. Now you're going to have an increased venous return because of this. Because even though the mean systemic filling pressure, your venous volume is not changed, there is an increased transmural pressure. This increased transmural pressure is going to cause an increase in the cardiac output. There is also a change in the cardiac function curve. So this is because as the RV becomes fuller, there is a concept of ventricular interdependence. When the RV volume increases, the LV diastolic function decreases. And like I told you earlier, whatever is changed, the diastolic function, the systolic function, there is going to be a shift to the down and right. So the cardiac function curve decreases slightly, but there is a far greater increase in the thing. So initially you had a cardiac output of say 4 liters, now you have 4.3 liters during negative pleural pressure. Suppose you take a short Miller maneuver, okay? So this is how we are going to look at this whole curve as we shift. So now let's go into more aspects of this. So once you inspire, you're not just going to have a negative pleural pressure, you're also going to have an increase in the volume. So you can see this red line as the increase in the volume from FRC to your tidal volume. So FRC plus tidal volume. So this is the state you have at end expiration with a normal spontaneous breath. So now two things are going to happen. First thing is that the increase in the lung volume is also going to affect your venous return curve. And this happens twofold. Now, one is that the increase in the chest volume pushes the diaphragm down and compresses the abdomen. So the abdominal pressure increases and most of your splanchnic or venous circulation is in the abdomen. So this causes a increase in the mean systemic filling pressure. So you have a shift in the circuit function to the right. Now this shift in the circuit function is going to be not the single thing affecting the venous return. Now the venous return can go to A or B depending on whether you are in a normovolemia or hypovolemia. In hypovolemia, what happens is the abdomen is compressed, right? So even though you think the venous return is going to increase, what actually happens is if you are hypovolemic state, there is going to be not as much increase in the mean systemic filling pressure, and there is going to be compression of the IVC in the abdomen. So there is actually an increase in the venous resistance to venous return. So you can actually have a decrease in the cardiac output in a hypovolemic patient with inspiration. Whereas if you have a normovolemic patient, there is not going to be much of a decrease in the venous resistance, this thing. So this venous resistance concept is usually seen in the echocardiography as venous collapsibility. So when you take a breath in, the vein collapses, right? So this venous collapse is more prominent in hypovolemia, and this more prominent vein collapse can even completely occlude the IVC temporarily, and this is going to increase the resistance. Now know that once it's collapsed, it's going to increase the distal, the downstream, upstream pressure, and that will again open it. But this causes a fluttering. Now this fluttering is going to ultimately increase the thing. So even though classically you're told, okay, spontaneous inspiration, increase in venous return, no, it depends on the loading state of the patient. So if you have a hypovolemic state, you will sometimes, this is an extreme case. This is not going to be a normal, a patient that hasn't drunk water for 2 hours hypovolemia. This is say a patient has hemorrhaged 1.5 liters of blood and your CVP is low. In that kind of condition, you're going to have spontaneous inspiration causing a fall in the venous inflow. So this is the kind of idea I want you to take, is that look at these curves, see what happens to the venous inflow, see what happens to the afterload, and then that is going to determine your thing. Now, what happens if we increase the positive pleural pressure? Now, when the pleural pressure is increased, you're going to have a shift of the abscissa to the right. So this curve, but ultimately the overall cardiac function does not change much. In fact, it improves a little bit as the RV becomes less distended because there's less venous return, and that decreases the venous ventricular interdependence and improves LV diastolic function. So in a normal patient, a pure small increase in the pleural pressure, such as with our Valsalva initially, will actually not will cause a small drop in the cardiac output. Okay, so purely from this point, but also what you have to consider is that the Valsalva positive pleural pressure also alters the venous return from the pulmonary veins into the LA. So that squeezes more blood out of the lungs, and that actually will cause a shift of the venous return to the LV. So this is where the LV and the RV act independently. So the Valsalva initially the RV venous return decreases, but the LV increases. But this is only temporarily. But within a few beats, what happens is the RV is having less venous return, the RV is going to have less cardiac output. That means the LV is going to have less venous return after a few beats. So with Valsalva, the LV also has less venous return and you have a lower cardiac output. Now let's talk about pulmonary vascular resistance as lung volume increases. Again, the time is a little short. Can we have some more time, ma'am, or should I? Okay, so I'll
Please
just
continue.
continue.
Please continue. Yes,
Okay.
please continue.
So if you take a look at the classically, we see this curve where we talk about lung volumes and vascular resistance of the lung. So this is what is usually described as a U-shaped curve. So the ultimate pulmonary vascular resistance in green, it decreases as you increase the lung volumes towards the FRC, usually by applying PEEP. And as it increases even further, that actually increases vascular resistance. So at FRC or close to FRC, the lung volume, there is the least vascular resistance. This is explained by two things. The red line is the intra-alveolar vessels. As the alveoli open up, by tethering the surrounding vessels, they open up the pulmonary arteries, they decrease pulmonary arterial collapse, and thereby they improve. So other thing is that alveolar atelectasis is decreased as your FRC improves. And if there is atelectasis, hypoxic pulmonary vasoconstriction causes an increase in PVR. So because of these two mechanisms, you see an improvement as a fall in the PVR. But as you go higher up, as you increase the lung volumes further, so there is even more increase in the PVR. This is because the extra alveolar vessels no longer have a decrease in the resistance. Instead, the intra-alveolar, the alveoli, the perialveolar, the pulmonary capillaries and the pulmonary arterioles right adjacent to the alveoli, they start to collapse as you go, as the alveolar pressure improves. So what you have is more of the lung going from West lung zone 3 to West lung zone 1 as the lung volume goes. So this is the whole concept. But this is the classical idea. Now, if we look along these curves, like we discussed above, this is the mean pulmonary artery pressure and the blood flow. So RV afterload, RV cardiac output, like kind of a picture. So here what happens is that this situation is way more complicated. So what happens is that a pure increase, like in the initial part, as you improve the FRC, the extra-alveolar vessels open, and that causes a decrease in the PVR. That improves the cardiac output for the similar mean pulmonary pressure without much change. But as you further increase the lung volume, you happen to cause a change in the Starling resistors and the curve shifts to the right. So what happens is you can have the patient go from A1 to B2. So you think there's not much of a change in the system, but actually what has happened is you have both improved the poisule, that is the alveoli, the pulmonary arteries are dilating and they are also getting compressed by the alveoli. So both of these things will happen simultaneously. So you will, the PVR which is measured in the classical formula will not change, but you will actually have an improvement in the RV hemodynamics. So you will see this as the RV becoming smaller. So the RV actually improves. So the PVR as a single measurement is not as good at describing this complex phenomenon. So now let's go to intermittent positive pressure ventilation. So what happens now? We talked about spontaneous. So in IPPV, there's a lot of things happening. Okay. So let's simplify it as what happens if you increase the pleural pressure alone. Okay. So we talked about that. Now, in addition to what happened to the pleural pressure increase alone, you also have an increase in the volume. And this increase in the volume causes a increase in the pleural pressures. Okay, because you have moved from the chest wall line, the compliance of the chest wall from here to here, and you have also caused an increase in the plateau pressure. Now, this plateau pressure is important because the plateau pressure minus the pleural pressure is going to give you your transpulmonary pressure. This is the pressure which is going to uh, compress your uh, uh, pulmonary arteries and cause a shift to the right. So in IPPV, you have multiple things happening. Now, first thing which happens is that the positive pressure is going to distend the diaphragm downward, compress the abdomen, and cause an increase in the mean filling pressure. So there is a shift to the right. Now, again, similar to what we saw earlier, there can be either in normovolemic patients, improvement in the venous return into the RV, whereas in hypovolemic patients, you can actually have the opposite and a decrease in the venous return into the RV as the IVC is collapsed because the abdominal pressure increases. So this is a concept you have to keep in mind. Now, the second thing which happens is that the RV afterload changes. Now, what happens when the RV afterload changes? You go from a higher the cardiac function decreases. It goes to down and to the right. So you have this gray line, this point, which is initially, now you have instituted positive pressure ventilation. You can have a slight fall in the cardiac output with a normovolemic patient, or in a hypovolemic patient, you'll have a great fall because you have both decrease the preload and the afterload. Now, this is why I'm going through all of these graphs and these curves, is because you have to understand that every patient reacts differently. So classically, the textbook will tell you, okay, you put positive pressure ventilation, your venous return improves, but afterload increases. So all of these, blah, blah. But you have to look at it. It's a very complex system, and it depends both, not just on whether you have positive pressure or not. It depends on what is the hemodynamic status of the patient already, which is why you have to think about giving fluids whenever you start IPPV, even in patients who normally have a decent mean circulatory filling pressure already. Now, PEEP is a different scenario. What happens is that the curve, the lung curve, you move rightward on the curve. Instead of moving from the FRC to the tidal volume, you move from a point slightly above the FRC to a point above the normal tidal volume. So you shift the curve to a higher point. So what happens is that the airway pressure is positive at the end of expiration. So there is not much of a change in the lung wall compliance for this same volume. So PEEP does not significantly alter the pleural pressure. So PEEP does not significantly alter the afterload per se by itself on the heart chambers directly. So, but what happens is that the venous system changes again. Now you go from this gray line to the blue line. So what happens with PEEP? You are having a higher abdominal pressure. So your PMSF, the ventricular, the mean circulatory filling pressure increases, but the resistance changes. And what also happens is the point at which the plateau pressure, the critical point, it moves to the right. So if you have a patient whose RA pressure is high, so then giving PEEP actually improves your cardiac output, the venous return to the heart. Whereas if you have a patient who is having a low RA pressure, giving PEEP worsens the venous return to the heart. So this is again very complicated, depending on the scenario. But once you apply these curves and think in terms of what is happening mechanistically in the Guyton curve, you can think, okay, this is what's happening to the venous curve, this is what's happening to the afterload, this is what's happening to the contractility independently. Okay, I've gone through a lot of physiology. Now let's see what happens in these disease conditions you encounter in the OT. Now, auto-PEEP is a very bad thing, as I told you earlier. So what happens here is that the curve, in auto-PEEP, in addition to the whole thoracic pressure increasing, what also happens is that this PEEP usually happens in the lower lobes. So the lower lobes become enlarged and they create a compression on the heart in the local area. So this is called a juxtacardiac pleural pressure. So even though your lateral pressure, your chest drain, all of that is negative, you can have a juxtacardiac cardiac pressure which actually goes higher. So you have to realize that it's not an entirely homogeneous area. So the pleura and the pericardium between the lower lobe and the heart gets compressed. So what happens is that the heart is going to have a decrease in the compliance. You're going to have reduced venous return because there is going to be a change in the line. So even though there is a shift to the right, because there is more abdominal distension, like compression, and an increase in the PMSF, the ventricular filling, circulatory filling pressure, there is still going to be a reduction in the venous return in certain scenarios. But in most physiological scenarios, small amounts of auto PEEP will actually improve venous return. Now, what is the problem is that even though venous return improves, the cardiac function decreases so much that the RV end diastolic pressure increases, RV end diastolic volume increases, the RV becomes distended, and that is going to deleteriously shift the curve to the bottom and to the right. So your cardiac output drastically decreases. So properly recruiting the lungs in the OT is very important, and avoiding auto PEEP is very essential. Now, a person, like say you have gone on CPB and you have come off CPB, you've not recruited the lungs properly. What happens is the base is still going to be atelectatic, and that is going to have a similar effect where you have the cardiac function, the afterload is greatly increased. So even though the venous return is improving, your afterload is very much increased of the RV, and that is going to cause a shift down. Now, once the RV afterload increases, the RV distance, and due to ventricular interdependence, even the LV is going to get adversely affected. Okay. So RV cardiac output decreases, LV cardiac output decreases. So auto PEEP net result is a decrease in this. So also the hyperinflation which occurs is going to shift the volume higher. So this higher volume is going to shift the compliance curves to a less favorable part. Work of breathing increases, but there is no thing. So in the post-op patients, you have auto PEEP and the work of breathing increases. So that is why the chest physiotherapy, where they blow the balls, the expiratory function, that is going to improve the opening of the airways and decrease your dynamic hyperinflation. So if you have auto PEEP and spontaneous inspiration, that actually does not affect it as much as when you are on mechanical ventilation. It is because of this. Now the time is a little short, but I will share the slides later, so those interested can take this. Now, pulmonary congestion, it is going to cause both a decrease in the pulmonary compliance and an increase in the airway resistance. So these are the stages of pulmonary congestion. Initially, you have the pericapillary, periarteriolar fluid presence. Then it goes into the adjacent airways and the tracheobronchial rings and all those areas, hilar components. Then it goes into the alveolar interstitial space. And finally, in frank pulmonary edema, you go into the alveolar space. So this is going to cause an increase in the airway resistance because, like I told you, it goes into the surrounding airways in B. The B is not written here because it is, behind the screen or like not shown. And it's going to cause a decrease in the compliance. Now, what happens? Suppose you have a patient with cardiogenic pulmonary edema who's on spontaneous. So what happens is you move the operating point in two ways. First, the cardiogenic pulmonary edema is actually going to improve your venous return to the heart because there is a change in the mean systemic filling pressure. This is because your in pulmonary edema, your intrathoracic pressure increases. So your body tries to compensate by taking more deeper breaths. So your diaphragm moves further down. So you are going to have a change in the circulatory filling pressure. So your venous circuit function improves. But what happens is the cardiac function decreases and you go more rightward on the RA. So this is because the transmural pressures on the heart. So your what happens is that another thing to note is that actually the x-intercept moves to the left because in pulmonary edema you are going to have a more the pleural pressure becomes more negative. It goes from -5 in a normal patient to -15 in a patient with cardiac pulmonary edema. I'm just exaggerating, but as an example. So this causes the curve to shift to the left, but because of the change in the pulmonary vascular resistance, you're going to have an increased afterload and the cardiac function curve worsens. Now in mechanical ventilation, similarly the cardiogenic pulmonary edema, there is not as much as a fall in the cardiac function. That is because you're going to have not as much negative pleural pressure trying to open up your lungs. Instead, you're going to have a positive pleural pressure. This is going to keep the transmural pressure constant because there is no change in the chest wall compliance. Therefore, the transmural pressure, the red lines here, as you move up in the curve, you're going positive pressure. So going from here to here, like from the FRC to here, instead you go from slightly upper to a higher point on the cardiac curve. So the pleural pressure increases. The pleural pressure actually becomes more positive, but the alveolar pressure is also more positive. So there is no change in the transmural pressure. So the heart operates in the x-intercept moves to the right. So what happens is you have a slight decrease in the cardiac output, but there is not much change, which is why in patients with cardiogenic pulmonary edema, mechanical ventilation doesn't have to be complete mechanical ventilation. Even giving some PEEP is going to improve the things. So classically, we are told that PEEP is just about, you know, changing the opening up the lungs, but it happens in many ways. So there is a difference between spontaneous and mechanical ventilation in a cardiogenic pulmonary edema, both on a venous return level, on the afterload and thus the cardiac function level, and also on the transmural pressure affecting what is going to be a venous inflow. So because of all of these things, mechanical ventilation is usually much better in patients with cardiogenic pulmonary edema. So even if you're not giving intermittent positive pressure ventilation, just giving some PEEP improves the cardiac output. Now ARDS, we usually think of it as a lung, but there is also extra pulmonary ARDS where the lung is fine, but you have the chest wall compliance altered. This is seen in infants with wall edema. It is seen in patients with ascites. It's seen in cirrhosis. It's seen in conditions where you have splinting of the abdomen in extreme obesity. So in these cases, the in pancreatitis is another example. So in these cases, the chest wall compliance alters, whereas the lung compliance is the same. So in classical ARDS, where we have an alteration in the lung compliance, which goes from here to here, the chest wall compliance is the same. So in these patients, the pleural pressure is actually not much altered when you give a positive pressure ventilation. Whereas if you look at these patients, like let's assume both are on positive pressure ventilation. So in a pulmonary ARDS patient, if you give cardiac positive pressure ventilation, so what is going to happen? You're going to shift the X coordinate to the right. You're going to have an increase in the PMSF, like we already discussed, but the cardiac function is actually going to worsen because the chest wall function is not much changed. So there is not a change in the pleural pressure, and because the pleural pressure is not changed, there is no change in the transmural pressure. So because the pleural pressure doesn't change, the transpulmonary pressure instead increases because the P plat to the PW increases. Now the whole concept is a little complicated, but you have to think as the lung as something which comes between the positive pressure ventilation and the pleura. Now in ARDS, the lung is stiff. So because the lung is stiff, whatever positive pressure you give into the lung is not necessarily transmitted to the pleura. So the pleural pressure is not significantly altered. So what happens is that you just have an increase in the plateau pressure. So the transpulmonary pressure increases. So actually the transpulmonary pressure is the pressure which is between the alveoli and the pleura. And what is between the alveoli and the pleura? Your pulmonary arteries. So if your transpulmonary pressure increases, the pulmonary arteries will get compressed. So this is going to cause a worsening of the arterial load. So your cardiac function curve shifts much to the right and below. So in these patients, you're going to have much worse. Like you're not going to have as much of an improvement when you initiate mechanical ventilation. In fact, the cardiac output actually decreases in these patients when you go on mechanical ventilation. So the lung function may improve a little bit, but the overall cardiac output is still going to decrease when you initiate mechanical ventilation in a patient with pulmonary ARDS. Whereas if you take a patient with extrapulmonary ARDS, there is going to be a much greater increase in the pleural pressure. So the RA pressure is shifted much to the right. The transmural pressure decreases. Because the transmural pressure decreases, the RA, the venous return to the heart is less. So what happens is that the axis, the x-intercept is shifted to the right. So what happens is you have a shift to the right, but the cardiac function is maintained because the transpleural pressure does not change. So whatever airway, the increased P plat is accompanied by an increase in the pleural pressure. So the alveolar pressure inside is high and the pressure outside the lung in the pleura is high. So there is not as much of a collapsing influence on the pulmonary arteries. So this is why you will not have a fall in the cardiac output with an extrapulmonary ARDS. So in extrapulmonary ARDS, if you initiate mechanical ventilation, the lung function will improve, cardiac function will not worsen. Whereas in a pulmonary ARDS, usually, even though you're thinking that mechanical ventilation will improve the lung, it will, but you will actually have a fall in the cardiac output. So you will end up using some inotropes or some vasopressors in these patients. Now, decompensated cirrhosis is a specific kind of case, and here you're going to have an alteration in the lung compliance. The ascites is going to cause your chest wall compliance to shift to the right, and the transpulmonary gradient is going to shift to the right, so your lung compliance is altered. So now if you take a look in these patients, you're going to have a way more complex physiology. So you have to see where on these curves you are. So whether you're going to have an improvement in the cardiac output by giving more fluids, or whether you're going to have an improvement in the cardiac output by giving more uh, PEEP, that is going to depend where on this curve. So it's going to change with the patient. So your lung compliance is altered, your chest wall compliance is altered, and thus your heart is in a very complex state. So if you have a sepsis on these patients, you're going to have a very bad time. And that is why in these patients with decompensated cirrhosis, the respiratory management is much harder than in a pure ARDS. Now, let's talk about respiratory distress and how, link it all to what we have talked so far. So this respiratory distress is going to be a common problem when you're extubating. So let's take this case where you have an obstructed lung, you have some degree of thing, and you're trying to extubate the patient. So once you remove the PEEP and you're going to have a spontaneous, or you remove the tube, the airway resistance increases. So once the airway resistance increases, you're going to end up with auto PEEP as the alveolar collapse occurs. So I'm sure you know what are the respiratory complications of these. I'm just going to talk about the hemodynamic complications when you have a patient with a bronchospasm who's extubated. So the airway resistance increases, hyperinflation and autopneumonia occurs, which causes a decrease in the lungs compliance. So that is going to cause a decrease in the venous return, because that interstitial pressure is increased. That increases the venous return, but the work of breathing also increases. Now, this hyperinflation in PEEP also increases the juxtacardiac pressures, because so usually in the lower lobe, and that increases the cardiac pressure more than it increases the PEEP. So that leads to RV dysfunction and LV dysfunction. Now, the LV is more affected by lung overinflation, because the LV from septum to lateral wall shares a much bigger border with your lungs, rather than the RV, which has a more of an anterior-posterior aspect. So the RV is more affected by LV dilatation, not as much by the lungs. So both of these cause an increase in the afterload, the increase in the work of breathing, increased work of breathing, the auto PEEP, all of which increases the PA afterload of the RV, which further worsens RV dysfunction. And RV dysfunction per se causes LV dysfunction by ventricular interdependence. And ultimately, all of these will cause your LV function to decrease and cardiac output to fall. So this is where you see these patients, we can go into a negative spiral, where in addition to the respiratory problems, you have a patient, a cardiac patient who's being extubated, and they will go into LV dysfunction. Now, whereas if you take a patient with a congested lung, which is seen in all these, severe MR in patients with very bad diastolic function. So the interstitial and alveolar edema increase airway resistance and decrease the compliance, and they again lead to all of these similar phenomena. And in addition, the elevated LA pressures will now they will cause all of these things. So you will get an obstructed lung picture. So even though the lung wasn't initially obstructed, you extubate a congested lung, you can end up with an obstructed lung picture, because the increase in the airway resistance and the decrease in the compliance so can cause all of these again. And these further feed into this and cause worsen it. In addition, the alveolar edema will worsen your RV afterload and cause RV dysfunction. So when you remove the intermittent positive pressure ventilation in a patient, so you can have the patient go from this point to this point. Like this is in a healthy patient. Okay, so the venous return is improved, the pleural pressure becomes negative, and therefore, but that doesn't cause an increase in the venous return, and the cardiac function curve doesn't. So in a healthy patient, you remove the IPPV, you get like a pretty good picture. Cardiac output can actually improve. So this is actually relevant in these cases where you have a fontan, or you have a single ventricle, or you have a patients where, there is a thing. So in these patients, the pleural pressure is going to determine how the venous return goes directly into the lungs. And in those patients, reducing the pleural pressure is going to improve. So a negative pressure ventilation in these patients is going to improve the venous return. Normally you're thinking venous return, okay, it's a little higher, little lower, but in these patients, decrease in the venous return is very dangerous, because that means that your Glen pressures will increase, and if the Glen pressures are higher, then you can have a cerebral edema, you can have problems, and you can have a reduced cardiac output. Okay, so there is going to be there is a lot of interaction with this with shunts and how they affect like complex congenital, which is too complicated to go in this video, so I'll refrain. So just know that when you remove the IPPV, you can go from A to B to D to C depending on the different state of the heart and the thing. So your afterload usually does not alter much with removal of IPPV. There's still going to be afterload whether you have spontaneous or mechanical ventilation, but you can have change in the venous return, and you can also have a change in the curve. So which point of the curve you are, and that depends on your thing. So if you have a hypovolemic state, you can go into C. If you have a euvolemic state, you can go into a D. So all of these things can change. So yeah. So I think like I hope I've not confused you more than I've explained things. So take home is what is good for the lungs is good for the RV. So if you improve the lungs and where it is on the respiratory curve, you are going to improve what is good for the RV. So whatever is improving your lungs, but improving the lungs is not just putting a lot of PEEP and calling it home, calling it a day. So you have to actually improve it. So heart-lung interactions are complicated. You can have one factor decreasing cardiac output, one factor increasing cardiac output. So the key takeaway from all of this is that in different patients, different things will be more important. In a hypovolemic patient, even though the afterload is reduced, if your uh, venous resistance is increased, you can have a reduction in cardiac output. Whereas in a patient who's in a failing heart, the afterload is more significant. The small increase in venous return is not going to help you. Instead, the afterload is the main factor, and therefore the cardiac output will fall. Auto PEEP is very bad, and Guyton is like really good. And I recommend whoever is interested in the subject to go and read his paper on venous return curves from 1955. Even to this day, it is phenomenally beautifully written. And I always say, and I always believe that understanding the graphs and curves will help you more than paragraphs of text. And I will, you can message or email me for the link to this PPT, whoever is interested. And references, I am not complete. And finally, one last thing is that please don't use AI. Every time you use AI, the environment is bad, the economy is bad, and you are just devaluing your profession. Kindly don't use AI. That is my thank you.
Any question? Audrija, why hypotension happens with increase in PEEP can be explained from the curves. I think Elvis has beautifully explained the whole thing.
I would like to add that PEEP will not always cause hypotension. PEEP will cause hypotension in hypovolemic patients. In euvolemic patients, PEEP can actually improve cardiac output in certain conditions. So like I said, you have to look at the curves, you have to look at all the different graphs, and you have to see where on these lines you are there. So increasing the PEEP will sometimes improve venous return and help things. Whereas in certain conditions, it is going to affect the afterload more. In that case, you're going to have a less cardiac output. So this is the main takeaway I want you to have. So the venous return, the Guyton curves, you have to see. So it's a complicated topic, but ultimately hypotension is not always seen with PEEP. It sometimes helps, especially in cardiogenic pulmonary edema, as I showed, the PEEP will actually improve things.
Excellent presentation, Elvis. Excellent discussion and explanation, really. Thank you all for being with us in this evening. And today's session on heart-lung interactions in OR and ICUs has given us a deeper clarity on the physiology that guides our everyday decisions in anesthesia and critical care. And we are sincerely grateful to Dr. Elvis for sharing his expertise in such clarity and humility and practical insight. That is very important. He has correlated the every theory with the practical cases that we deal with our day-to-day practice. So his word will surely guide us in our future clinical practice. A heartfelt thanks to all the participants for your time, for your engagement, and continued support to our Heartline mini series. So your presence strengthens our academic community and inspire us to keep learning together. So we look forward to our next